Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse and CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. This program was made possible through support from both our donors and our industry partners. At this time, I would like to introduce our moderator. Thank you.
Thank you, Robin. I am Stephen Feldman, a longtime CLL patient advocate, member of CLL Society's Patient Advisory Board, a senior support group advisor, as well as co-facilitator of the City of Hope CLL Society support group. I would like to welcome you all to today's event. We are joined by Dr. Heather Wolfe, Assistant Professor in the Department of Internal Medicine and Director of CLL Survivorship at UT Southwestern Medical Center in Dallas, Texas. Dr. Wolfe will discuss the definition of survivorship, why it is important, and explain the importance of secondary cancer screenings, how to prevent infections, vaccinations, bone health, cardiovascular health, and mental health. And we now welcome Dr. Wolfe.
Hello, I'm Heather Wolfe, an assistant professor in internal medicine and our director in CLL survivorship at the UT Southwestern Simmons Comprehensive Cancer Center in Dallas, Texas. Today, I'm going to talk about a really important topic, how we can help our patients not only survive, but also thrive after their CLL diagnosis. My goal is to arm you with information to create the survivorship team to help support you throughout your CLL journey. Let's jump right into our learning objectives. First, we'll start with why we need survivorship care in CLL, which often requires a multidisciplinary team. Then we'll move on to infection prevention, secondary cancer screening, cardiovascular health, and how we can modify any risk factors to potentially decrease our risk for cardiovascular events, bone health, mental health, and then we'll end with some additional survivorship recommendations. Before we get started, I wanted to highlight how far we've come in the management of CLL. Between the 1950s to the 1980s, we really just had single agent chemotherapy, for which 50% of our patients typically responded. However, complete responses were rare. The 1990s brought combination chemotherapy, which improved both the response rate as well as complete response rate for our patients. However, one of the biggest advances came in the late 1990s with the discovery of rituximab. Rituximab was later combined with chemotherapy agents and gave us really impressive outcomes. Despite the improvements with chemoimmunotherapy, we still had a sizable group of patients who had inferior responses, even with chemotherapy agents such as FCR and BR. But fortunately, now we're in the age of targeted therapy, which has been dominated by the BTK inhibitors and the BCL2 inhibitors such as venetoclax. Still, we have wonderful overall response rates and, importantly, favorable outcomes even in our high-risk patient population. With the improvements in our treatment of CLL, our patients are living longer than ever before. And this was a study published in 2021 that looked at the causes of death in patients with CLL now in the age of targeted therapies. Of note, after diagnosis, these patients lived on average of 17 years, and the average age at the time of diagnosis being 65. So in this group of CLL all-comers, this included both low-risk and high-risk patients. 34.6% of patients who died of their disease. 20.6% of patients died of a CLL unrelated condition. And the most common causes included cardiovascular disease, which included both heart failure and heart attacks, followed by neurologic diseases, most commonly dementia and stroke. 16.4% of patients died of a secondary malignancy. And the most common cancers that we saw causing death in these patients were lung cancer, colorectal cancer, and pancreatic cancer. And lastly, 5.6% of these patients died due to an infection. Putting it all together, what areas can we improve when it comes to helping our CLL patients live longer? And the four main areas that pan out include infection, secondary malignancies, cardiovascular disease, and cerebral and neurologic diseases. When it comes to infection, vaccines are important to prevent severe infections, hospitalizations, and death. When it comes to secondary malignancies, being up to date on age-appropriate cancer screenings and yearly skin exams are important. As for cardiovascular disease and neurologic disease, aggressive risk factor modification, blood pressure control, diabetes management, smoking cessation, and physical activity become important. Many of these things we don't routinely talk about in CLL clinic, which is why we need participation from a multidisciplinary team, which often requires primary care and other providers who are actively taking care of our CLL patients. So during this talk, we're going to discuss this term survivorship. So I think we should talk a little bit about the definition that the NCCN and other groups use to describe a survivor. We often think about a survivor with breast cancer or lung cancer who've been cured of their disease. However, a cancer survivor includes all patients who have been diagnosed with cancer, including those living with the disease. So therefore, our chronic cancer patients should receive the same high-level multidisciplinary care to help them live long, healthy lives. When it comes to living with CLL, many focus on the disease, symptoms related to the disease, and the treatment. And these are all really important, but there's a number of other factors which play a significant role. These include emotional well-being, making sure patients remain physical and have adequate mobility, management of other medical conditions, financial well-being, safety, and social interaction, all which we know play an important role in quality of life. Where multidisciplinary survivorship model really comes into play. While us as oncologists are good at managing the disease symptoms, treatment and treatment side effects, we need the help of our friends in psychology, physical therapy, nutrition, primary care, and social work to help us manage these other areas, in addition to other physicians and other specialties. And maybe of highest importance is support from friends, family, and community. So as the title of this talk, we're going to address some topics to help us not only survive, but also thrive during the CLL journey. And these highlighted here are some of the topics that we're going to talk about. Again, surviving, infection prevention, prevention of secondary malignancies, cardiovascular risk factor modification. And in order to help us thrive, we're going to maintain physical function through paying close attention to bone health and supporting mental health during the journey. So let's kick it off with infection prevention. As many of you know, patients with CLL are at increased risk for infection. The increased risk of infection is a function of both the disease itself and can be only worsened with treatment for CLL. Studies have shown that patients with CLL are not only at increased risk for infection, but also risk for severe infection, hospitalizations, and death from infection. And this includes influenza, pneumococcal pneumonia, and most recently, COVID-19. So what can we do about it? Most of what we're going to be talking during this talk is vaccination against diseases that we have vaccines approved for. But the other thing that I did want to touch on is immunoglobulin replacement. This is a common question that we get in clinic. Many of our patients with CLL will develop low antibody or immunoglobulin levels throughout the course of the disease. I routinely monitor immunoglobulins or antibody levels for patients, particularly if they are on treatment or have had CLL for a long period of time. And when we talk about replacement for low antibody levels or immunoglobulins, studies have shown that routine immunoglobulin replacement across the board is not recommended. It's not found to be efficacious or give any improvements in outcomes. However, patients that have IgG levels less than 500 or history of recurrent infections, IVIG or intravenous immunoglobulin can be considered. The biggest thing I wanted to discuss when it comes to infection prevention is vaccines. And this is a busy chart, but it is pulled right off the CDC website that shows us the recommended vaccines in the immunocompromised patient population. And everyone with CLL would be considered immunocompromised and should follow these recommendations. And the vaccines highlighted here are COVID-19, influenza, tetanus, diphtheria, pertussis, sometimes known as Tdap or TD, zoster, the shingles vaccine, HPV, which we'll briefly talk about, and the pneumococcal vaccine series. Hepatitis B and Hib or vaccines are not usually required additional doses in our CLL patients. To make it a little bit easier, this is the list of vaccines that I often go over with my patients. So first up is the yearly influenza vaccine. One thing to note, in patients with CLL and other immunocompromising conditions, we typically avoid live vaccines. And for the flu vaccine, this is the intranasal or the vaccine that is given through the nose. So we would avoid the intranasal vaccine and go with the regular recombinant influenza vaccine once a year. We also recommend the pneumococcal vaccine series. This has also recently changed with the approval of PCV20, which is a one-dose vaccine to cover for pneumococcal pneumonia. Also PCV15, followed by PPSV23 is also approved. Pneumococcal vaccines can be confusing, so you're not sure what you had. Feel free to reach out to your oncology team or primary care team, and we can make sure that you've been adequately vaccinated. The COVID-19 vaccine series is something we'll also talk about, as remains always a hot topic. Recombinant zoster vaccine or Shingrix is also recommended in CLL patients. Again, the Tdap or TD booster is recommended every 10 years. An HPV vaccine is something that I don't think we talk enough about, but we are seeing more and more young patients with CLL, and this is something to talk about. It's typically given in patients under the age of 26. However, if patients have not received it, would consider up to 45 years of age. And hot off the press, the RSV vaccine, which was recently approved and we'll be planning to roll out this fall, has been approved in patients greater than equal to 60 years of age. So all patients 60 years old of age or older, I would recommend this. And the one thing to note is treatment can affect how you respond to vaccines. So it's important to talk to your doctor about when is the optimal time to receive your vaccines. Sometimes it may be delaying until after completion of certain treatments in order to get the best response after these vaccines. But I recommend talking to your doctor a little bit about this. So COVID-19 vaccination has been getting increasingly complicated over the last 2 years with creation of all these different types of vaccines. So the CDC put out a chart to help patients figure out what additional vaccines they need based on what they originally had. I know there was recently a CLL Society webinar on COVID-19, so I direct direct you to that. But in general, for those who've not been vaccinated, the bivalent vaccines are recommended. But for those who received early Moderna or Pfizer vaccines, the monovalent variety, further doses with the bivalent vaccines are recommended. But when it comes to further COVID-19 boosters, what do we know? After completion of your full vaccine series, an additional bivalent vaccine is recommended. However, the benefits of further bivalent booster vaccines remains unclear. So at this time, we recommend shared decision-making between you and your doctor to decide whether or not that would be effective and beneficial for you. Best treatment. However, what's available if you do come down with COVID-19? Paxlovid is our go-to outpatient treatment. However, one thing to note, you always have to talk to your doctor or your pharmacist because there are a number of drug-drug interactions that can become dangerous if not reviewed previously. If Paxlovid is not an option for you, remdesivir has been approved both in inpatient and outpatient settings, can be very effective. The only problem is it is given intravenously, so it can be a little bit more tedious when trying to arrange outpatient infusions. Monoclonal antibodies and Evishield are no longer recommended or routinely given, just as they've been found to not be efficacious in our new COVID-19 variants that have been circulating. So we'll move to secondary cancer screening. As many of you know, patients with CLL are at increased risk for other cancers. This again goes back to the impaired immune system driven by CLL as well as the treatments. And this is one of the largest studies that followed almost 25,000 patients with CLL. And in this cohort of patients, 18% were diagnosed with a secondary cancer. As you can see here in the green, solid tumors were much more common than secondary blood cancers. They did also note that the highest risk of secondary cancers occurred after 5 years of being diagnosed with CLL. So it seems like the longer time patients have CLL, potentially the higher risk, likely due to the effects on the immune system. The other thing that they found kind of correlated with secondary malignancies was prior use of chemotherapy. When it looked at what type of solid tumors were most common in this patient population, they saw higher rates of colorectal, lung, non-melanoma skin cancers, as well as prostate cancers. And these are the most common cancers that we see in individuals without CLL as well. However, notated by the stars, there were a few cancers that we did see higher than expected case rates than in the CLL population when compared to the general population. And that was found in lung cancers, melanoma, non-melanoma skin cancers, as well as kidney cancers. When it came to blood cancers, they found cases of other non-Hodgkin's lymphomas, multiple myeloma, acute myeloid leukemia, as well as myelodysplastic syndrome. And again, with both non-Hodgkin's lymphoma and acute myeloid leukemia, these case rates were higher in the CLL population than compared to the general patient population. So what can we do to prevent deaths from secondary cancers? We can encourage routine cancer screening in all of our patients. Before we talk about the details of screening, there are a few important things to highlight first. First, know your family history and discuss it with your physicians. Second, know your medical history, know your treatment history, as these can also play a role. And finally, discuss your doctor, your risk for different types of cancers. There are a number of different factors that can place individuals at increased risk for different types of cancers. So it's really important to take into account when coming up with a cancer screening plan, as it really can vary between individuals. The guidelines for cancer screening vary greatly between different groups and societies. And I'm going to highlight what I typically use for my patients, but this can again vary depending what group of recommendations you're reading. Again, also to highlight, this is for patients who are at average risks of these cancers. If you have family history or other risk factors, your cancer screening may vary. Again, talk to your doctor about what's right for you. So first up, skin cancer. I recommend yearly dermatology visits with full skin checks for all of my patients. If you or your doctor notice a new spot, you'll likely be referred to a dermatologist and a biopsy will likely be warranted. The dermatologist will help work with us and figure out if any other treatments required. But if you do have history of other skin cancers like basal cell or squamous cell carcinomas, you may end up seeing your dermatologist more than once a year. For colorectal cancer screening, the age to start screening recently changed. So now they're recommending starting colorectal screening at age 45. There are a number of different modalities that have been approved for colorectal screening, which includes stool-based tests such as Cologuard, colonoscopies, as well as CT colonographies, which is a CT scan of the colon that can detect bigger polyps, but are sometimes more difficult to detect the smaller polyps. If you think about it, the stool-based tests and the imaging tests like the CT scans aren't able to intervene on polyps if they find positives. But there's benefits and kind of downsides of each of these modalities. So again, talk to your doctor about what best may fit you. For mammograms, most groups can agree that we should do mammograms in women between ages 50 to 74. Now, again, different groups recommend yearly versus every 2 years. And I typically discuss with my patients who are younger than 50 and who are older than 75 if we should start mammograms or breast cancer screening early or continue it after age 75. For patients with history of smoking, low-dose CT scans can be performed yearly. And prostate cancer screening is also an area of hot debate. The current recommendations is for shared decision-making, but if you do decide to do prostate cancer screenings, typically PSAs are drawn typically between starting at the age of 50 through 75. Again, this can be repeated every 1 to 2 years, but prostate cancer is one where risk factors are really important. Whether it's family history or certain races can put you at higher risk for either early prostate cancers or more aggressive diseases. So again, talk to your doctors about what's right for you. Lastly, for our younger female patients, we shouldn't forget routine cervical cancer screening, which continues through age 65. Switching gears a little bit, but talking about cardiovascular health. Again, optimizing cardiovascular health comes down to risk factor stratification. Typically, this can be done in consultation with a primary care physician or a cardiologist if needed. Patients should be screened for pre-existing heart disease or other conditions that put them at high risk for heart disease. Routine blood pressure monitoring, cholesterol monitoring, blood sugar, hemoglobin A1C monitoring is often performed routinely to optimize these conditions if needed. Family history is also really important, so it's good to know and review your family history with your doctors. Prior or ongoing treatment can play a role in your cardiovascular risk or other side effects, so this needs to be reviewed with your team and monitor for some of these toxicities. Lastly, review of your current diet and exercise habits is really important. Many factors go into an individual's cardiovascular risk, and tools exist to help quantify this risk. The American College of Cardiology has a calculator that helps predict your 10-year and lifetime risk for a cardiovascular event, and this includes heart attack, stroke, peripheral artery disease, or risk for heart failure. So your doctor plugs your information in, and out pops your cardiovascular risk. So for instance, this patient who we just made up, their 10-year risk for a major heart attack or stroke is 23.9%. And the lifetime risk for that is about 70%. The other helpful part of this calculator is it shows with optimizing certain risk factors, you can significantly decrease this risk. So for instance, with this patient, through quitting smoking, starting a statin, potentially blood pressure medication, as well as a baby aspirin, you can reduce that risk from 23.9% to 8.6%. And it also gives a summary of different things that patients can do. So this helps not only patients, but also more importantly, their healthcare providers figure out how's the best way to counsel them when it comes to starting medications and other lifestyle changes. So how can we generally and overall improve your cardiovascular risk? It starts with management of chronic medical conditions. So talk to your doctor about adding a baby aspirin or a statin, and your doctors will help you weigh the benefits versus risks of some of these medications. But going back up to chronic medical conditions, if you have high blood pressure, adequate blood pressure control, whether dietary changes or addition of medications may be helpful. If you have high cholesterol levels or history of high cholesterol in your family, are there dietary changes you can start? Or maybe it's time to start a cholesterol medication like a statin. Patients that have history of prediabetes or diabetes, maybe it's worthwhile talking to a nutritionist about a diabetic diet or management of diabetes through the number of different medications that are now available. It's also important to stop smoking or using tobacco. If you do, this helps not only your cardiovascular health, but a number of different outcomes, including risk for secondary malignancies like we were talking about earlier. And lastly, encouraging regular exercise. The American College of Cardiology recommends 150 minutes weekly of regular exercise. Again, it doesn't have to be in one burst, but kind of sprinkling 30 minutes, 5 days a week counts as well, but regular exercise is recommended. Speaking of exercise, another thing that exercise is good for is your bones. Bone loss and bone health is not something that we routinely talk about. However, it's really common in the United States. This is a study that looked at the incidence of osteoporosis or low bone mass in adults in the United States between 2017 and 2018. And in this study, they found that 43.1% of Americans were found to have low bone mass. And 12.6% of Americans qualified for osteoporosis, which is actually considered a medical condition of weak bones that requires treatment to prevent fractures. And as we know that bone loss increases as we get older, so patients over the age of 65 in this light green box had higher rates of bone loss as well as osteoporosis, and women are more likely to have increased bone loss as well. So why do we care about bone health and low bone mass? Because they increase your risk for fractures. And this was a study that looked at 1 year mortality following a hip fracture. In all comers, 20 to 30% of patients died within 1 year of sustaining a hip fracture. And this risk of death only increased to 40 to 50% in patients who were living in nursing homes when this happened. This is a study that I participated in that looked at rates of vitamin D deficiency, bone loss, which we call osteopenia, and osteoporosis in CLL patients, and then a group of non-CLL patients. And we controlled for a number of different risk factors, which we know contributes to low bone mass, including age, race, and gender. And despite controlling for these variables, we found that patients with CLL had higher rates of vitamin D deficiency, low bone mass or osteopenia, as well as osteoporosis. Surprisingly, we also found that patients who met criteria for osteoporosis were less commonly prescribed medications to help with their bone, improve their bone density, and did have higher rates of fractures later on. Should be done about maintaining bone health, and bone health screening. So we know that bone health screening is approved in all women over the age of 65. In younger women, younger than 65, it is also approved for those who have any of these clinical risk factors. Men, bone health screening is recommended in those with manifestation of low bone mass, which may be height loss, history of low trauma fracture, or again, any of these clinical risk factors for fracture. We hope to further study bone loss in CLL patients to see if routine screening would be beneficial as well in our patients. But at this time, I would recommend talking to your primary care team to see if you would benefit now for screening. After screening has been performed, what do we do about it? If you've been found to have normal bone mass, congratulations, you can continue doing what you do. Again, we still recommend a good diet and weight-bearing exercise, but you can consider repeating bone density again in 10 years, especially if your risk factor or risk factors change. If you have been found to have low bone mass or osteopenia, calcium and vitamin D supplementation is encouraged in addition to weight-bearing exercise, and also avoiding alcohol and tobacco use, which can negatively affect your bone mass. Lastly, if you're diagnosed with osteoporosis, there are a number of bone strengthening medications that have been found to maintain or improve your bone density, and also importantly, reduce your risk of fracture. Lastly, one of our most importants to talk about is mental health. Mental health is unfortunately not something that we talk about enough in clinic in our communities. But studies have shown that our cancer patients struggle with several mental health challenges related to their diagnosis and their treatment. The first being general distress or fear of recurrence or disease progression, general anxiety, depression, and PTSD. Routine screening is required to be able to catch and treat these mental health struggles early. A number of different screening tools are available and should be routinely used in clinic. This is the distress thermometer. Many of you may recognize this from clinic screening. There's a test and kind of screening for PTSD or post-traumatic stress disorder. PHQ-9 is used to identify patients at high risk for depression, and the GAD-7 is for anxiety. There are a number of people who we work with to help patients dealing with mental health struggles. Our cancer center has cancer-specific social workers, psychologists, psychiatrists that are trained to help support our cancer patients. Primary care physicians in your oncology team are also there to support you. But lastly, having family and community support is invaluable. So what can you do to support your mental health? One, openly talk to your oncology team. Sometimes the unknown can be scary, and it can be helpful about talking about your true prognosis and risk for disease progression, which can make you actually feel better. Establishing with a mental health provider, if needed, can be very helpful. Implementing lifestyle changes, such as focusing on sleep and physical activity. Spending time with family and friends. And lastly, connecting with other cancer survivors or other cancer patients who've maybe been struggling with the same things you have. Along that line, I want to highlight the support groups that the CLL Society has. I have a number of patients who have joined our Dallas CLL Society support group, and they tell me really cool things that they've been doing and really interesting discussions that they've had and feel like it's very beneficial. But there's a number of different support groups throughout the United States and a couple as well in Canada. So I recommend everyone going to the CLL Society website and checking it out to see if there's one close to you. I also wanted to highlight the mental health services on the leukemia lymphoma website. These links range from helping finding mental health professionals to supporting family members to wellness retreats for young cancer survivors. Lastly, I wanted to highlight the last few recommendations for our chronic cancer patients, which include maintaining and engaging in physical activity, maintaining a healthy diet. We recommend a varied diet. There's no one diet that is better than the others, but it's a well-rounded diet, high in fruits, vegetables, whole grains, vegetarian diets, pescatarian diets, and even meat eater diets can all fit in this recommendation. Drinking alcohol sparingly. Again, avoiding the use of cigarettes, tobacco products, and e-cigarettes. We've talked a lot about skin cancer, so practicing sun safety. This includes using sunscreen or other types of skin protection when you're going outside. And lastly, something we can all work on doing better with, sleeping 7 to 9 hours regularly. So in conclusion, I wanted to leave you with the idea that patients can and do live long, rich lives. It's important to stay up to date with vaccinations to prevent disease and also significant side effects related to these diseases. Establish care with a primary care team to stay up to date on cancer screening, management of risk factors, as well as comorbid conditions. Talk to your oncology team and about mental health struggles and help seek assistance when needed. Lastly, lean on your community and join support groups so you know that you're not alone. On that note, I'd like to say thank you all for being here, and I'm happy to take any other questions or comments or any other suggestions or thoughts. Thank you.
Okay. Thank you, Dr. Wolfe, for a very information-packed presentation, very helpful. Just a reminder, no one is expected to remember and recall everything that Dr. Wolfe presented today, but you can find today's presentation on our website very shortly. So when you go to our homepage, again, go to the Programs and Support tab, and then when you scroll down, you'll see Education on Demand, and today's webinar should be up very shortly. So before we launch into today's Q&A section, we have a few brief poll questions that you'll find on your screen. So please scroll down to see and answer all 5 poll questions. The first one is, before this event, I was aware that having CLL increases the risk of secondary cancers. Select yes or no. Before this event, I was aware that having CLL increases the risk of osteoporosis. Yes or no. I have experienced increased anxiety and or depression since my or my partner's CLL or SLL diagnosis. Choose the answer that's most appropriate. Number 4, I feel comfortable talking to my healthcare team about mental health issues. Single choice, choose the one that's most appropriate. And the last poll question, I have adequate access to resources to help with anxiety and or depression, such as support groups, education, caregiver support, professional help, and more. Again, choose the answer that's most appropriate for you. So to the first question, was I aware that having CLL increases the risk of secondary cancers? 89% of you said yes. Regarding osteoporosis, a majority of you, 81%, were not aware that CLL poses an increased risk for osteoporosis. The third poll question, I'm scanning along with everybody else. Most of you, a plurality, answered that you agreed that you've experienced increased anxiety and or depression since you or your partner has discovered having CLL. Next, number 4, again, scanning this in real time, a plurality, 48% of you agree that you feel comfortable talking to your healthcare team about mental health issues. That's good to hear. And lastly, number 5, 49% of you agree that you have adequate access to resources to help with anxiety and or depression, such as support groups, education, caregiver support, professional help, and more. Okay. We welcome Dr. Heather Wolfe back to answer your questions. and we'll try to get to as many of the audience questions as possible. But if we're not able to get your question for any reason, please send them to our Ask the Expert email address. After this event, we will share this email address on our closing slide. So thanks to everyone who submitted advanced questions for this event. And I'm going to start with the first advanced question. Can the taking of venetoclax, which is a BCL2 inhibitor, or any of the new targeted therapies taken either as monotherapy, which is just one drug, or in combination with other CLL drugs, ever result in a cure? And when CLL is fatal, what are the most common reasons for that?
Thanks, guys, for this question. Thank you all, first of all, for being here. And the poll kind of highlights how, well informed this group is when it comes to not only CLL, but also the kind of side effects and other things that we look for it. But talking a little bit about a cure for CLL, isn't that kind of crazy that we're even putting those words in, the same sentence? But in 2023, what we have currently, I usually don't use the word cure when it comes to CLL yet. In CLL, we do have wonderful different treatments that provide long, durable periods of remissions for patients. But again, I don't know if I would use the word cure in that same way. Let's take the CLL-14 trial, for instance. That's what approved venetoclax plus obinutuzumab, one of those anti-CD20 antibody therapies in the frontline setting for patients. So these were patients that had not received prior treatment and did receive the venetoclax-based treatment. With long-term follow-up, we've found that patients who are now off therapy for 4 years, about 63% of these patients still remain in remission, and about 70% of them remain off treatment. But if we kind of look deeper into how deep of responses we're seeing, they still may have clinical remission. But when we do the minimal residual disease tests, or MRD testing, these are tests that look to see in a deep level if there's any circulating CLL disease. You can usually detect it up to, I think, 18% of those patients at the 4-year mark after stopping treatment were MRD negative. So in 18% of patients, there was no evidence of CLL. But for the remaining 82% of patients, even if it was a small circulating number, they still saw some CLL in their blood tests, even in really deep levels. So for 82%, did frontline venetoclax provide a cure? No, but the 18%, who knows? We really need kind of further follow-up and more tests to see if in maybe a small subset of patients, we are really getting really deep remission. So currently, I would say I would not use the cure word quite yet, but we're getting darn close. So there's really good treatments, which are really exciting. You asked the other part of the question. Yeah,
the other question is the dark side. When CLL does prove fatal, which is increasingly less common today, thankfully, what are the causes that cause that?
No, thanks for re-asking that. But like we were saying, most commonly it is infection or other non-CLL related things that do cause mortality in our patients. But let's say outside of those, what causes mortality? So one thing that we always worry about and hate talking about is Richter's transformation. So transformation from low grade CLL disease process to a higher grade type of lymphoma, which can be more challenging to treat and has higher risks of mortality. The other thing that we think about is risks of other blood count changes. So we talk about high blood counts when it comes to CLL, but often as CLL progresses, you will see increased anemia, that's low red blood counts, as well as thrombocytopenia, low platelet counts. And those can also cause side effects whether it's bleeding or symptomatic anemia in patients. But most of the time, I would say mortality results as a side effect of infection, kind of in the setting of immune dysregulation.
Would you agree that many CLL experts say that we'll die with the disease and not from it?
So that's a hard thing to say, and I think from patients that I've talked to, people feel split about how they like hearing that, because they want kind of what they're going through and what their disease to be taken seriously. So I think, as we saw in that presentation, that a big chunk of patients with CLL in 2020 were dying of something else. So our greater than 50% of patients, I think it was like 70% of patients died of something else. Yes, that's true, but there's still that chunk of the pie, that 30% of patients who are dying related to their CLL. So statistically, is it more likely for something else? Yes, but still, let's not kind of forget about the disease itself.
Okay, next question. Many of us either have at diagnosis or will develop over time severe hypogammaglobulinemia or depletion of our critical immunoglobulins. How do we continue to live and thrive with CLL when our immune system is functioning subpar? Can targeted therapies, oral meds, infusions boost or maybe even reconstitute our immune system?
So that's a good question. I think there were a number of other kind of similar hypogammaglobulinemia questions in the chat. So just briefly touching on that. So throughout a patient's CLL disease journey or disease course, most patients will develop hypogammaglobulinemia. And we know that patients with more advanced disease and those who had CLL for longer periods of time are at higher risk. So we can give different therapies to support patients who do have hypogammaglobulinemia, like intravenous IVIG, which is an infusion of antibodies that can help support patients, but it is not recommended across the board for all patients, regardless of infection history or IgG levels, just because it has not been found to reduce the risk of severe infections. And that's what we care about. We care about preventing severe infections. So other ways, how can you improve your IgG levels or antibody levels? Right now, there's not great data that shows us other ways to do it, or how do you reverse the hypogammaglobulinemia. There was one study out there that thought that ibrutinib may have slightly increased the IgG levels in patients, but that's not been shown in other studies. In fact, certain treatments, like rituximab anti-CD20 antibodies, actually can lower IgG levels while you're on treatment. So that should be monitored in patients who are on other antibody treatments and other therapies throughout CLL course. But typically, this is something that I follow in my patients. Obviously, people that have lower levels, I follow a little bit more closely. And those that have never had treatment or things have been stable, you can follow them a little bit farther. But IVIG can be effective in some patients if they do have history of recurrent infections and low IgG levels.
Is it true that the IgG levels, when they're low, doesn't necessarily correlate to an increase in infections?
Absolutely, and I think that that's going to be part of some of the other questions. So antibody levels are only part of the immune response. So there's a couple different arms when we come to think about our immune response. So one, we think about our humoral immunity that responds to the antibodies. And then there's a whole other arm called cellular immunity. And that has nothing to do with the antibodies. So different types of white blood cells kind of play roles in different arms of the immune system. So by just focusing on the IgG levels, you're actually missing out on one whole arm of the immune system. So it's not the whole story. So you can have an IgG of 450, but if you've never been infected, then maybe bumping that number up, may not help. And kind of a counter, I have some patients who IgG levels are well above 500, but they do have recurrent infections. So I don't think it tells the whole story. And I think that's why kind of the recommendations for IVIG can be confusing.
Yeah, I think that's an important point because as patients, I think we focus on the data that's available that we can get from a blood test, but there's a whole spectrum of other information that it's not so easily gleaned that plays as important or maybe more important role in our disease progression. Next question. It relates to fatigue. Someone says, can you explain why I feel so tired after being diagnosed with CLL? Quote, it seems I have become more tired as time goes on. Does fatigue typically worsen over time? Will treatment lessen fatigue? And then someone in the chat box asks, how frequent does fatigue show up with someone who's at stage 0 CLL?
So fatigue is probably the number one complaint that I hear across the board from CLL patients, from those who are recently diagnosed without any enlarged lymph nodes or blood count changes to people that have had CLL for a long time. So really it's one thing that we commonly see across the board. So what causes fatigue? So there's a couple different theories. So one, if you have blood count changes related to your CLL, for instance, anemia with low red blood counts, that can definitely make you more tired. But like you were saying, those early stage CLL patients also have fatigue. And the theory for that is cancer cells produce chemicals called cytokines. And cytokines in our blood system, just like when you have cytokines can also be produced not only from cancer cells, but infection, just those immune cells can create these chemicals, and these chemicals can make you feel more tired. So we think it's that these circulating cytokines in the system related to the CLL that can produce the fatigue. So what can we do about it? Can treatment make it better? So sometimes it can, sometimes it can't. So I have patients who have fatigue, they get started on treatment, the fatigue gets better because we're treating their CLL, and that's a win. So there's other patients who you put on treatment and their fatigue potentially worsens. And the reason why is because a lot of our therapies can also, one of the things on the list of side effects is fatigue. So I think it depends a little bit about what's driving the fatigue as to maybe if they're going to improve with treatment for the CLL. I often don't recommend starting treatment just for the fatigue, just because I've had a number of patients that are disappointed when it's not improved with treatment or treatment itself makes it worse. So it's kind of important to look at the big picture. Definitely, if you have other indications that need treatment, then it's something, that you need to get started on, but it's not something that I typically treat or start treatment for just for the fatigue. So some people seem to have improvement, some people don't. Just other things that we can do outside of treatment to kind of help the fatigue. I always recommend, if this is something that's new, talk to your doctor. Let's make sure that there's no other reasons why you're feeling tired. We got to check, make sure your thyroid's healthy, making sure that you're not having cardiovascular disease or other reasons for feeling more tired, especially suddenly. Other things, I know this is boring and we're going over and over again, but exercise and getting outside and healthy diet, these all are things that you can also do by yourself that can try to help improve your energy levels.
Is there any role for ADHD drugs used to treat fatigue, like Ritalin or Adderall? Because I have heard about that, though I don't have any direct experience.
Yeah, so there have been studies for cancer-related fatigue and some of the ADHD medications. I don't use them myself typically in practice just because of the side effects from these medications, especially as we're thinking about starting them in some of our older patients. The risk for heart effects or kind of tachycardia, meaning fast heart rate. I don't love them, especially if they're on other treatments like the BTK inhibitors. It makes me a little bit nervous. So kind of frontline always, or making sure there's not another reason for people feeling fatigue. And two, also coming up with non-pharmacologic ways to help manage it. So could you use these other things? Maybe some providers kind of routinely do talk to your doctor, see what they think, but I'm a less is more medication type of person. If we can try to treat things without another medication, the better.
Moving on to infections. So someone writes, is the vulnerability to getting infections greater or lesser during watch and wait, also known as active observation, versus when they're in treatment?
So good question. So the short answer is yes, potentially so. So people who are not on treatment or who have never been on treatment, really you're seeing the immunocompromised or lowered immune system just from the disease. So there are a number of different kind of points in the immune system that CLL attacks to make you more vulnerable. But then again, putting treatment on top of that kind of further complicates it and can add an extra layer of immunosuppression. So we think that, for instance, after you've been off treatment, so the anti-CD20 antibodies like rituximab or obinutuzumab that we often use old school when we were using chemotherapy, but now combined with things like venetoclax, we start to see, so that one usually produces the longest periods of immunosuppression. We think 6 to 12 months after treatment, you're still effectively immunocompromised from the treatment, taking CLL, the kind of underlying immunocompromise from CLL out of the picture. So it takes some time for your immune system to reconstitute after treatment. So people who are on treatment or recently have been on treatment are at the highest risk for immunocompromise and an increased risk of infections.
So when you say reconstitute, you just mean getting back to its CLL pre-treatment level, not to back in the time before you ever had CLL.
Yes. So there's a number of different kind of mechanisms that the infusions can add to the mix, and it's before the pre-treatment, if you will.
Right. So getting to treatment here, I know someone writes, somebody commented that her husband is taking zanubrutinib, which is a BTKI inhibitor for SLL, and would like to know for how long he can continue to remain on that drug.
So great question. So zanubrutinib is one of our newer BTK inhibitors on the block, but that whole class of medication are what we consider as continuous therapy. So those medications are typically continued either one until intolerable side effects or two disease progression. So most of our patients who start on the BTK inhibitors can take them long term. And we have the most data for ibrutinib, where I have patients who have been on it for almost 10 years. So that's super exciting that it's been effective. And also, there's a group of patients who have been able to escape the side effects of these BTK inhibitors. So if it's working for you and side effects are manageable, we keep patients on it.
Someone writes with a confusion, I think, about the distinction between relapsing from treatment and getting Richter's syndrome. Can you?
No, and that can be confusing in some of these terms that we throw around very loosely. So typically when we think about relapses, when patients who have had, stable disease, whether that's blood counts, lymph nodes, some sign of disease being stable, whether it's from treatment or on its own. So I think of relapses a slow kind of gradual increase in white blood cell counts. You can see decrease in red blood cell counts, decrease in platelet counts, or changes in your lymph nodes. So basically increased CLL disease activity is what I think about as relapse. So Richter's is a little bit of a different picture. So CLL is classically thought to be a slow or more indolent leukemia or lymphoma, which typically can develop over years. So Richter's is when that slow growing or indolent leukemia or lymphoma changes to a more aggressive form of lymphoma. Most classically, it's changes to what we call a large cell lymphoma, which is kind of a different disease process all itself, which requires different treatment, typically going away from the BTK inhibitors or the venetoclax by itself, but we have to combination chemotherapies in order to manage it. So more aggressive management for a more aggressive disease.
What is the incidence of Richter's, and are there treatments for it?
So good question. Yes, there are treatments for it. So we typically think that it's 1% per year in certain patients. So there are patients that are at higher risk of Richter's, so certain mutations that we've known to see, but most of our patients that we see do not have Richter's transformation. So I don't want everyone going away from this worried about that, but it's something that all of the CLL doctors have a high index of suspicion. When it comes to treatment, we usually use a combination of chemoimmunotherapy. So this is a combination of a medication like rituximab plus chemotherapy. Sometimes we'll add venetoclax or BTK inhibitors along with that just to control the CLL portion of it, but usually it's chemoimmunotherapy. And other new, more novel treatments such as CAR-T and stuff can be used in these settings as well.
Back to vaccines. Someone asks, quote, after being double vaccinated with both shingles vaccine, Shingrix, is there a need for me to begin using acyclovir, which is an antiviral drug, on an indefinite basis? And then I'll add to that, because I'm 6 years post-treatment and I'm still on maintenance acyclovir, as I think most of my oncologist patients are. Is there any reason why I wasn't put on acyclovir before I started treatment, seeing that I was already immune compromised?
So good question. So this brings up the idea of antibiotic or antimicrobial prophylaxis. So if you go across the board and talk to probably 100 different CLL doctors, you may get 100 different answers when it comes to how long we're keeping antimicrobials on board. I'm actually working on a trial to try to see if we can figure this out and get some more kind of definite guidelines. But antiviral prophylaxis is something that probably most CLL physicians can agree on. So patients who are on therapy, so for instance, if I'm going to start a BTK inhibitor or start somebody on venetoclax, I will start acyclovir at the same time in most of my patients, even if you've had Shingrix before. And the reason why is it doesn't just prevent against the herpes zoster, it also prevents against herpes simplex infections as well. So we think that it's suppressing other types of kind of viral reactivations in patients that are higher at risk because of the ongoing treatment. So for patients on continuous BTK therapy, probably most of the time patients or physicians will keep patients on it while they're on treatment. So when patients get off treatment, that becomes a little bit more murky, and there's probably different opinions when it comes to that. Most of the time I'll keep my patients. So let's say somebody completes therapy with venetoclax and obinutuzumab. I'll usually keep them on for a minimum of 6 months after treatment. One thing that I have seen people do is you can check something called CD4 count. And that's measuring that other part of the immune system I was referencing, that cellular immunity. And that can help kind of guide how the immune system's doing after treatment. And some people will follow that and kind of change prophylaxis accordingly. But I have seen people keep acyclovir on long-term, but typically if people are doing okay, 6 to 12 months out, you can kind of check to see how their immune system is doing and can consider taking them off. But again, talk to your doctor. There may be a reason why they kept you on it. That's always important. There's factors that maybe they're considering that we're not talking
Or how
about.
they were trained.
100%.
Yeah. I think that, reading into the questioner's concern, what is the safety profile for acyclovir?
So that's a funny thing that you ask. Even between me and some of my colleagues, there's some people, like you were saying, that put everyone on prophylaxis, and then there's some that are a little bit more conservative. But everyone argues, or you'll hear people argue, that acyclovir is safe and people don't normally have side effects to it. It's most of the things, if you look at the black or the back of the box, it will be the normal things. Fatigue, you can see people have some nausea, GI upset, rash can happen with it. But most times we do not see significant drug toxicity related to acyclovir, but that doesn't mean that doesn't happen. Again, things that we were talking about, fatigue's on the list, right? So
I would assume that would show up early and not if you've been on it.
It usually does. And for most of the patients who are on it, they've been on it for what, a year or two, right? Before we even talk about taking it off, even in people that have had fixed duration treatment. So my practice, like we said, for the BTK inhibitors, typically if someone's tolerating it okay, I continue it during the BTK inhibitor treatment. But for fixed durations, I think it's something to talk to your physician to see if at some point they feel comfortable taking it off.
Okay, thank you. Let's pivot to COVID. Someone writes, how much more at risk is a CLL patient with COVID today than someone in the general public with COVID? And they qualify it by saying, I understand CLL patients have a 40% chance of dying if they got COVID early in the pandemic, and know that has changed for the better, but by how much?
So I think that's $1 million question. So we had early studies that unfortunately showed that our CLL patients, those on treatment, even those who were not on treatment, had more severe side effects, hospitalizations, ICU stays, and unfortunately mortality related to COVID. So with the new variants and with all the changes, different studies have found different results. I was actually kind of looking at some of these to see if there was any new or updated studies regarding this recently, but with the new variants, including like Omicron, there were a couple studies that showed mortality rates ranging all across the board. I saw one that had 0 mortalities and one that still had kind of higher levels of mortality. But I think these were studies that, again, are not done today. I think the variants are one piece of the puzzle here, because not only are we seeing more clinically less severe variants, but one, patients are more, heavily vaccinated now. 2, hospitals and ICUs are better at treating COVID than they were kind of in the early days when those high mortality rates were reported. And then we also have better treatments, whether it comes from Paxlovid that we're routinely giving our patients to minimize the risks of severe COVID infection. So I think there's a number of different pieces in addition to just the variants that are making us better and better at treating and managing COVID infections. So anecdotally, I can tell you we are seeing many less CLL and others, fortunately, with COVID in the hospital as well as the ICU. So I would think that the mortality has significantly gone down, even though some of the studies have wide ranges of mortalities reported.
Okay, now I'm going to ask you a really difficult question, not because it's complicated, but just because it's so wide ranging. I think when people get the diagnosis, obviously they want to do something. And if you're in watch and wait, active observation, you feel a little bit helpless. So, and I know you addressed some of these things in your presentation. Is there a dietary intervention I can take? And I know there's maybe no specific diet, but people still want one. And exercise. How often should I exercise? Is one type of exercise better than the other? So I think everyone's looking for something where they can just sort of put the brakes on the progression, if not reverse it altogether, which is not too likely, but at least if they can slow down the progression. So are there any trends that are emerging that would suggest do this, this, and this, and your odds of getting to to the point of needing treatment will diminish a little bit?
So like you said, this was a hard question.
Sorry.
So there's a number of things that I kind of recommend on a routine basis to our watch and wait patients. So one, like we were saying, exercise. So physical activity is important in all of our patients. Not only, there's been some studies, actually a group that I worked with previously, looked at the effects of high intensity training in older patients with CLL and actually found some immunomodulatory, meaning effects on the immune system and how it regulated the CLL, as well as lymphocyte counts after 12 weeks of high intensity training. Do I think all of my patients have to do high intensity training? No. I think what the American College of Cardiology recommends is 150 minutes of exercise a week. Again, we're
that
not
could be swimming or walking even.
So I think the best thing in an ideal setting, could you do a combination of cardio and resistance training, because that gets the heart pumping with cardio, and then resistance training helps the bones that we were talking about. So I think it's maintaining muscle mass, getting the heart pumping, keeping the bones healthy through a variety of different exercises. But guess what the best kind of exercise is? The one you'll do. So I think whatever it is, whether you enjoy walking for 30 minutes 5 times a week, that's great. If you like to go to the gym and lift light weights, fantastic. If you like swimming, that's great. I think having a physical regimen that you like to do that gets you out and moving around will help you in a lot of different ways. So when it comes to diet, I have a lot of people that ask me, like we were saying, what's the optimal diet? And probably like all the diseases that we see and treat, there's not one diet that is the right for everyone. I don't recommend people adhering to a low sugar diet or a keto diet or anything like that, unless one of your other doctors have recommended it. I don't have patients avoid sugar per se, just because there's a fear that the sugar feeds the cancer, feeds the CLL, and it's a different type of sugar that we're talking about than the sugar that we're eating. I tell my patients to eat a regular, well-rounded diet. The diet that actually has the best data is the Mediterranean diet. So if you can eat a diet that is rich in whole grains, fruits, vegetables, healthy oil, some kinds of proteins, whatever you enjoy eating, whether it's healthy meat products or fish or beans, that's what's recommended, and it can help you feel better too. And then lastly, the one thing, I think I saw a question maybe in the chat box, is the importance of stress. So stress management is another thing that I think is really important in our patients during the watch and wait period. It's easy for us to say, hey, don't stress out about this. But there actually have been some studies that have looked at the effects of stress on CLL. And again, some of these cytokines and different chemicals that we can measure in the blood on clinical trials. And it's important to work on stress management activities, again, whether it's exercise or hobbies or spending time with friends and family. Living well, it seems to be some of the best things that we can do to, well round us. So the other things, when you're kind of talking about supplements or things that you can take, it's always a hot topic. So if you're on any treatments for CLL, please talk to your doctor, your pharmacist, because a number of these different supplements can interact with your treatment. That's the last thing we want to do. So make sure that there's no drug-drug interactions. But a lot of these supplements that people bring up to me haven't been studied in the large randomized clinical trials, like some of our pharmaceuticals that we use routinely.
Can you give an example of the supplements that people usually take? Or
So, yeah, the ones that people have brought up recently. So green tea is always a hot topic when it comes to CLL, since there was some studies that have suggested that it kind of improves CLL progression. So there's other studies that have shown the doses of green tea that it takes to get these effects cause stomach aches and GI distress, even tachycardia, that fast heart rate. Do I think people need to take high doses of green tea extract in pills? No, but if you enjoy drinking a couple cups of green tea a day, go for it. Vitamin D is one that has been shown to improve CLL outcomes. So for instance, patients, I always check a vitamin D level in all of my new patients. If you're vitamin D deficient, I do recommend taking a vitamin D supplement. But some ones that I think have less data behind them are things like turkey tail. So that has been one that a number of my patients have actually brought up. It's a type of mushroom. I actually looked it up with one of my patients and had the pharmacist help weigh in on that as well. Again, a lot of things, there's a lot that we don't know about the human body and how it affects different diseases, but it can interact with some of our medications. So in that case, we had the patient avoid turkey tail because it could interact with the BTK inhibitors. So if you're interested in taking these supplements, make sure to check with your doctor first.
Let me follow up with you about vitamin D, because the RDA on a bottle of vitamin D might say 150 units or 500 units, whereas many people take much higher doses of that every day, like myself. So if you consult with a nutritionist, they might just give you the company line or whatever it says on the label, because they don't necessarily want to go outside of an authority. So what do you recommend as a general dose? I know it's not one size fits all, but
you're completely right. So we usually check it. So people that have severe vitamin D deficiency need those high weekly doses, like the 50,000 units weekly, in order to get their levels up higher. It also varies depending on where you live, how much vitamin D you're getting, whether it's in the diet or with outside sun exposure. Speaking of that, there's always the controversy. We're supposed to stay out the sun, but then we need vitamin D. What's the right thing to do? But typically people can take, especially those who are worried about their bones, sometimes people take a calcium vitamin D together, but usually we recommend, like you were saying, 5,000, daily can be for people that are not having significant vitamin D deficiency or other things like that. But again, if people are having osteoporosis, osteopenia, other severe vitamin D, we usually consult with our endocrinologists or other nutritionists for further recommendations. But it's always good to also get it through food and other ways as well.
and my understanding, and you can correct me if I'm mistaken, it's very hard to overdose on vitamin D. You've got to really go overboard for a long period of time, and very overboard for a very long period of time.
So you're correct. The only reason why I take a second to hesitate is I actually have seen 2 vitamin D intoxications this year in the hospital from really, really high, but they were taking it in multiple different types of sources, including calcium too. So it's pretty hard, but I wouldn't do the 50,000 units, every day for a long period of time.
Someone asks, why and how are secondary cancers caused?
So that's a good question. So again, we get back to the immune system in patients who have CLL. So the immune system is really important in making sure we're keeping foreign invaders out. So oftentimes we think about it when it comes to the infections, right? But then the immune system is important in surveilling the body against cancers. So there's a number of treatments that we use for different types of cancers, including solid tumors, that actually help rev the body and their immune system to identify and fight cancer. So when your immune system isn't working as well as a person who does not have CLL, it can lead to the lack of detection by your body or being able to fight it off. So we think it's related to the immunocompromised state in patients with CLL.
Someone asks, what are the chances of needing treatment and when? How fast can this progress? So I think that question, I'm not sure if this is exactly what they're asking, but there's a large cohort of people diagnosed with CLL who never require treatment. That's great, and when that happens. So roughly, what are the current statistics regarding that?
So I typically think to about up to a third of patients get diagnosed with CLL and never need treatment. And then kind of the other 2/3, most of those patients will be able to be on the observation or watch and wait routine up until there's an indication for treatment. There's a small subset of patients who I see at the time of diagnosis and need treatment then. But they're, like we were saying, about a third of patients never need treatment. So in that kind of chunk of the watch and wait who do require treatment, how can you predict when you may need treatment? So there's a number of different prognostic calculators and different prognostic tools that your oncologist can use to help you predict when you may need treatment. And a number of factors go into these. Kind of one important thing is the prognostic studies. So these are things like the IGHV mutation or TP53. These are things that the CLL Society really, talks about a lot to make sure that these tests are being done in our CLL patients, because they can impact when you may require treatment. So prognostic markers can play a role. 2, another thing that typically goes into these prognostic tools are your lymphocyte count. So patients that may present with a lymphocyte count of 50,000 may require treatment a little bit earlier. And then lastly, that something that goes into one of the prognostic tools is lymph nodes. So if you can feel lymph nodes on exam. But some of these different tools we can use to calculate your risk and when we expect you may need treatment. But like I tell patients, they were not all on this study. So it's just a tool that we can use to give a guess based on people like you, but it varies upon a number of different risks.
Okay. I think, I would ask another question, but I think we have like 1 minute, and I don't think it would take me a minute to ask it and you more than a minute to answer it. So I'm going to ask you if you have any closing thoughts, and then we'll get close to adjourning.
Sounds good. Well, thank you all for being here. First off, what an exciting time it is to take care of our CLL patients. We're so lucky to have multiple safe and really effective treatment options to offer. which can lead to periods of remissions and long-term survival. But I think the next frontier is to help support our patients' quality of life through managing treatment side effects, prevention of infection and secondary cancers, and keeping people healthy and happy for long periods of time. And then I have patients who are in their 80s and 90s who come into clinic and tell me about a family trip they just went on or spending time working in their garden. I know that we can do it. I know we can help patients live long, happy lives. So thanks all for coming and participating. I saw a number of really good questions that were asked. Feel free to reach out. We're happy to talk more about what survivorship looks like in the CLL.
Well, on behalf of the CLL Society, thank you so much for this presentation and for dedicating your life's work to this.
Thank you all.
Okay, once again, we'd like to thank our generous donors and grant support from AbbVie and AstraZeneca for making this event possible through their support. Thanks to all of you for joining us today, and a big thank you to Dr. Heather Wolfe for her presentation. Please complete our event survey and provide your feedback to help us plan for future events. This virtual event was recorded and will be available on our website along with a slide deck. If your question was not answered, please send it to asktheexpert@cllsociety.org. Join us for our next webinar on September 27th about why policy matters, understanding how your CLL or SLL journey is affected. And please remember, CLL Society is invested in your long life, and you can invest in the long life of the CLL Society by supporting our work. Together, we can improve the lives of those with CLL, SLL, and thank you very much.